Right. Very good evening, guys. So finally, your NEET PG is over. I think what a relief, no? We will be waiting for this day from so long, and finally it is done. Usually, you should feel like doing. You should. I didn't get sleep after my exam was over. That entire night I was awake. That is like खत्म हो गया. What I was waiting for all this time, is it over? वो एक feeling रहती है. So I just hope you all have done great and you're all going to get your dream seat and dream college, right? So I'm here to discuss obstetrics and gynecology questions. If you ask my opinion on obstetrics and gynecology question, except one question, other all questions I felt wow. And this is the pattern which of questions you should get. Because this is everything from your notes. Only thing is that you had to apply it. And those who have applied it wonderfully are going to score it. Right? So, and as well, we have practiced these type of questions many times prior also. So I want you people to tell me what is your opinion. I have seen some students messaging that Obgyn paper was tough, but I felt tiny CT was tough compared to this. This was all something which we usually discuss. So, right. So you can also follow me on my Telegram group, guys. So what is your opinion, guys? What is your opinion on the paper? Okay, did you plan how to enjoy post exam? Yeah, एग्जाम्स आते रहेंगे, टेस्ट देते जाएंगे, बट आई टेल यू ऑल ऑफ यू डिजर्व लिटिल एंजॉयमेंट. तो थोड़ा ब्रेक ले लो, रिलैक्स अ लिटिल, वॉच सम मूवी एंड डू समथिंग नाइस and then plan something further, right? But do take a break, guys, but do take a break. So first question, right, before I start the questions, they are not these are what I've got from the students. So the questions and options might be different and there can be some either other, but you can guide me as well. If you feel any option which I've given or the question which I've given is difficult, is wrong, you can let me know it. Okay. A case of preeclampsia post cesarean section. Patient is type 1 diabetic and her blood sugars are 280 milligrams per deciliter. Patient was drowsy. Her respiratory rate is 10 cycles per minute. Urine output is showing oliguria. Both patellar reflex is bilaterally absent. What is the cause for her drowsiness? Magnesium toxicity. I could get around 17 questions, KJ. So, magnesium sulfate toxicity, diabetic ketoacidosis, postpartum eclampsia. So, what do you think might be the cause for her this drowsiness? Now, it cannot be postpartum eclampsia because she doesn't have convulsions. So, for postpartum eclampsia, you should have convulsions. But as there is no convulsions, I'm not considering this, right? Diabetic ketoacidosis, sugars should be very high, right? 500, 600 range may. So, this also not, this codes very well with magnesium sulfate toxicity. This goes very well with magnesium sulfate toxicity. So this, I think you all would have read about the magnesium sulfate toxicity. We all know that magnesium sulfate acts by suppressing the NMDA receptors. So whenever you give excess dose, it can lead to coma. That is why she is going into drowsiness. It can lead to respiratory depression, which this lady already has. The first to be lost is patellar reflex, which is already lost here, right? So whenever there is magnesium toxicity, the first to be lost is patellar reflex. So when will be patellar reflex lost? So patellar reflex will be lost when the magnesium toxicity has gone to 10 to 12 milliequivalents per liter. Followed by, you'll have respiratory depression. and followed by you'll have the patient going into coma. So this is very classical of magnesium toxicity. So your answer will go for magnesium toxicity. Okay. Right. Very good. Excellent. You all have answered it correct. Excellent. Next question. Patient was having normal blood pressure, normal coagulation profile also. Her AST and ALT are 75 international units. LDH is 400. Platelet count is 75,000. What is the most appropriate diagnosis? Cholestasis of pregnancy, HELLP syndrome, AFLP, acute hepatitis. Okay, so let us see how do we differentiate between all of these and then again come back to this question. Okay? So normally jaundice in pregnancy, the differential diagnoses are hyperemesis, cholestasis, fatty liver, preeclampsia or HELLP and hepatitis. Hyperemesis is usually seen in the first trimester where you have severe nausea and vomiting. Her AST levels will be normal to 300. Cholestasis of pregnancy presents to you with lot of pruritus and very mild jaundice. There also AST levels will be normal to 200. Fatty liver presents to you in the third trimester. They'll have nausea, vomiting, hypertension, and they can also have liver failure. Her AST levels will be around 200 to 800. 200 to 800. Next, preeclampsia or HELLP, normal limit to 300. Hepatitis, AST or ALT level will be 2000 plus. So, what are the two options which are ruled out now based on our AST and ALT levels? Fatty liver is ruled out and hepatitis is ruled out. Because usually in this, it will be in hundreds, guys. Yeah. And please see here, coagulation profile will be deranged in fatty liver. Coagulation profile, see fibrinogen, pro will be very much decreased, prothrombin time will be increased, D-dimer will be increased, hemolysis is there, right? Creatinine and hematocrit will be increased, bilirubin will be 4 to 10. So coagulation profile will be deranged and AST and ALT levels will be around 1000, 800, 200, right? So this cannot be acute hepatitis or this cannot be AFLP because coagulation profile is normal. That's why I'm ruling out AFLP and the AST ALT range is not should be around 200 to 800, but here it was around 75 to normal. है ना? So now left is cholestasis and HELLP. Cholestasis में you don't have platelets decreased. See here, cholestasis में platelets will be normal limit. Cholestasis में platelets will be normal limit. So this clearly fits into our HELLP. Hemolysis, elevated liver enzymes and low platelet count. So as there is hemolysis, LDH is raised. Elevated liver enzymes, not much elevated, but yes, AST-ALT is around 75, that's fine. Low platelet count, because platelet count is 75,000. So this fits exactly to our HELP. So the answer here is HELP. Are you all satisfied why the answer is coming to HELP? So was the patient normotensive? So patient is 34 weeks of gestation. So even if the patient is having normal blood pressure, I'll still go with the HELP itself. Okay. But I have Pragadish telling me that blood pressure of the patient is 150/90. Then though it is like there is no confusion only. Right? So AST and ALT can be between normal limit to 300. So you can quickly watch this. This one is very important even for our further. Always we should know how do we differentiate clinics में भी बहुत बार you will see fatty liver cases and HELP cases, but HELP is little more commoner compared to fatty liver. So hyperemesis will present to you in early hyperemesis. They'll have severe nausea and vomiting. Their AST will be normal limit to 300. Bilirubin level will be normal to 4 milligram per deciliter. Previously also there was one question similar to this in JIPMER, I think so, last JIPMER May, where this bilirubin level and everything. So this is not something which is new or naya question hai. Many times they give you differential diagnosis of AFLP and HELP. Okay, creatinine will be raised in hyperemesis because of the excess vomiting. There will be pre-renal failure. Creatinine raised, hematocrit raised, platelet, fibrinogen, D-dimer, prothrombin time, all these will be normal limit in hyperemesis. Cholestasis, onset of pregnancy is late. They'll present mainly with pruritus, and that too, when will you have high pruritus? Nocturnal pruritus. So again, it will be normal to 200. Bilirubin will be 1 to 5. But rest all will be normal. Creatinine, D-dimer, coagulation profile, everything will be normal in cholestasis. Fatty liver also in third trimester, they'll present to you with nausea, vomiting. They can also present to you with hypertension and liver failure. So here AST range will be 200 to 800. Bilirubin will be 4 to 10 and creatinine will be raised. And these patients will have abnormal coagulation profile. They land up in DIC usually. So platelets decrease, fibrinogen decrease, D-dimer increase, prothrombin time increase, and there's a lot of hemolysis. Preeclampsia, mainly the HELP syndrome, can present to you with jaundice. So they'll have hypertension. Normal limit to 300 will be the AST. Bilirubin can be 1 to 4. Creatinine will be increased. Hematocrit will be increased. Platelets will be decreased. D-dimer can be increased, but prothrombin time and fibrinogen will be normal. Hepatitis may, there'll be severe jaundice and AST will be more than 2000 and bilirubin will be 5 to 20. Here the platelet count can be little decreased, but her D-dimer and fibrinogen will be normal limit. Okay, so based on her AST being in a normal range, I'm going with the answer of HELP syndrome, as well as there is normal coagulation profile which is more favoring me towards the HELP syndrome. Blood pressure can be normal. It is not like it should be high. So when she comes to us, the blood pressure would have been normalized. So that is fine. Next, this is one of my favorite question and I always make you practice this. So I am excited you people to tell me whether you all answered this correct or not. Primary with normal regular cycles now delayed for 2 weeks with vaginal bleeding. There is a right-sided lower abdominal pain. Beta HCG is 1400. Her UPT is positive. Blood pressure is normal. On adnexa is also normal. On USG, there is trilaminar appearance. What is the next step in the management? Very good, excellent. I see now so many of you answering it correct. Who can tell me what is this called as? So when UPT is positive and if you don't see pregnancy anywhere, what do you call this as? When you don't see the pregnancy and it's either in the sac or in the uterus, this is called as pregnancy of unknown location. So whenever you have pregnancy of unknown location, what should be your next step? Your next step should be measuring the beta HCG. What should be the minimum amount of beta HCG to visualize? What should be the minimum amount of beta HCG to visualize? This is called pregnancy of unknown location, guys. When you don't see the sac anywhere, then although UPT is positive, you call it as pregnancy of unknown location, right? So what should be your next step? You should measure the serum beta HCG. So what should be the minimum beta HCG to visualize the gestational sac on the TVS? The minimum beta HCG to visualize the gestational sac on TVS is 1500. But as here the beta HCG level is 1400, it's obvious that you'll not see anything on the anything in the TVS. So that is why what you should do, you should do serial beta HCG monitoring every 48 hours, and that is what was your answer. So you should do beta HCG after 48 hours. So I think all of you have answered it correct and excellent. Yes. So on transvaginal sonography, the minimum amount of beta HCG to visualize the gestational sac is 1400, 1500. Yes, excellent all in one. 1500 for TVS and 6500 around for 5000 to 6500 for transabdominal scan. Very good, Shiv, Sujit, excellent. Sairam. So when you're doing serial beta HCG every 48 hours, if the beta HCG level rises, so last time they have given the rise ka question, but this time they asked what is your next step. But this was a repeat question, guys. So if beta HCG rises by 63%, then what is your diagnosis? Very good, Dr. TJ Gaming, excellent. So when you're doing serial beta HCG every 48 hours, if the beta HCG rises by 63%, then your diagnosis is it's an intrauterine pregnancy. It's an intrauterine pregnancy. If the beta HCG level rises above 50% but less than 63%, then it is a ectopic. If there is a fall in beta HCG or rise less than 50%, then it is failed intrauterine pregnancy. Failed intrauterine pregnancy, right? Okay, right? So that's why your answer will go for beta HCG after 48 hours. Right? Next question, the structure being given during the structure which is being pulled during traction got torn and led to excess vaginal bleeding. Which of the following is the most appropriate next step? Okay, fine. So what should be, what is this procedure? It's a Brands-Andrew method or control cord traction. So as it is Brands-Andrew method or control cord traction, and if the cord gets cut, what should you do next if the cord gets cut? Uterine massage won't help now. Oxytocin you would have given before itself, no? As soon as the baby has come out, you would have given oxytocin. So why do you want to give again oxytocin? So when the cord is cut and there's bleeding, now there's no point that this placenta will come out. So you can do the manual removal of placenta. So you will do the manual removal of placenta. Okay. Creed's method is outdated. We don't do Creed's method. Okay. Right. So there was one more question where they have asked, what is this? What is this? Right. So they have asked, what is this? I have actually, you have it written here. So this is the zone of mid pelvis. So this is the zone of mid pelvis. So zone of mid pelvis is from the plane of greatest pelvic dimension, that is from the posterior surface of pubic symphysis to the junction between S2 and S3. So zone of mid pelvis will be from plane of greatest pelvic dimension to plane of mid pelvis. So this which they have given is the mid pelvis. That's what students have told. So same thing I have written. So this is the plane of greatest pelvic dimension. Was it the same one which was given in the exam? Was it the mid pelvis itself? So how will you tell that this is mid pelvis is? This is bound between plane of greatest pelvic dimension to plane of mid pelvis. So what is this plane of greatest pelvic dimension? It starts from the midpoint of the posterior surface of pubic symphysis to the junction of S2 and S3. And plane of mid pelvis is from the lower border of pubic symphysis to the junction of S4 and S5. So here S4 and S5 will be here. So that is why this is the mid pelvis. Okay. Below the mid pelvis will be the obstetrical outlet. Below the obstetrical outlet will be the anatomical outlet. So obstetrical outlet will be from the lower border of pubic symphysis to plane of least pelvic dimension. So what is this least pelvic dimension? So plane of least pelvic dimension is from the lower border of pubic symphysis to the tip of ischial spines and S5 and S5. So from the plane of least pelvic dimension to lower border of pubic symphysis to the tip of coccyx. This is called as obstetrical outlet. Below the obstetrical outlet, you will have the anatomical outlet. And above the mid pelvis, you have the inlet. I think again inlet we have already discussed the boundaries, and as you want it to be quick, so I am going to just go to the next question. Okay? Right. Okay, at what level is the uterus to be felt on second day post delivery? At what level is the uterus to be felt on second day post delivery? So we all know that uterus, the rate of decrease in the fundal height is around 1.5 to 2 centimeters per day. So 1.5 to 2 centimeters is 1 finger breadth, no? So one day post delivery will be 1 finger breadth below the umbilicus. Second day post delivery will be 2 finger breadths below the umbilicus. So it will be 2. 1.5 to 2 matlab is 2 finger breadth. So you should have answered for 2 finger breadth. Okay. So rate of decrease in the fundal height is 1.5 to 2 centimeters per day. Right. So by second day it is 4 centimeters. 4 centimeters means 2 finger breadth. 4 centimeters means 2 finger breadth. By 2 weeks it will become a pelvic organ. By 2 weeks it will become a pelvic organ. Okay. In embryological development, testis should release testosterone. So what makes it release the testosterone? Again, this is directly from your notes. So what is the answer for this? And this I do ask you in the class also, right? So in embryological development of testis should release the testosterone. So what makes it release the testosterone? And yes, correct, that puerperium is usually asked in the postpartum when in your ward rounds. So HCG from the placenta is the one which makes the release of testosterone. Why? HCG from the placenta. So the functions of HCG is it maintains the corpus luteum. The functions of HCG are it maintains the corpus luteum. It maintains the corpus luteum. It helps in the growth and development of the umbilical cord. This is the primary stimulus for the release of testosterone from male fetus and immunosuppression. Why is this acts as a primary stimulus is because it is structurally and functionally similar to LH. So it is structurally and functionally similar to LH. That is why it acts as a primary stimulus for the release of testosterone from the male fetus. So HCG from the placenta is responsible for the release of testosterone from the male testis. Yes, I missed one question. I'll come back to this question in the last. Again, one of my favorite question, and I really loved this question, and I want to see how many of you have answered this. So multigravida was in second stage of labor for more than 2 hours. On pervaginal examination, fetal head is palpable at the level of ischial spines in right occipital transverse. Sagittal suture is palpable in the transverse diameter of inlet. Moulding and caput is plus. What should be a further management? Now, before I ask you what is the further management, what is the diagnosis here? What is the diagnosis of this? Who can tell me what is the diagnosis of this condition? Very good, excellent, Keshav. So this is the deep transverse arrest. This is deep transverse arrest. This is deep transverse arrest, right? So as it is deep transverse arrest and in multi, you have already waited for 2 hours. So if you remember, we have that in second stage, that table. Primary, remember in the table, 1, 2, 3. Multi 30 minutes, 1 hour, 2 hours. So when labor has gone more than 2 hours in multi, this is called as second stage arrest. And the reason for the second stage arrest is here, deep transverse arrest is leading to the second stage arrest. And the arrest of the fetal head is at the level of ischial spines. That is, head is too high up. You cannot put any instruments when when fetal head is at the level of ischial spines. So your best answer here will go for LSCS. Your best answer here will go for LSCS. Okay. Very good, Purnima Agarwal. Excellent. Very good, Omkar. Yes, this is the second stage arrest due to deep transverse arrest. So obviously, when you have second stage arrest due to deep transverse arrest, what should be your management? So second stage arrest for deep transverse arrest will be LSCS. So if you remember, I make you always write the table, and if you follow the table, this answer is very simple, and just clinically, this much is there. Yeah, even if there is a previous history of cesarean section or no history of cesarean section, doesn't matter, our answer will not change. It will go for LSCS itself, because it is second stage arrest due to deep transverse arrest, right? And only when fetal head is less than below +2 station, and if it would have been only in prolonged second stage, that is only 1 hour would have been over, then I would have thought of putting vacuum. But now here there is no point of putting any instruments. You have to go for the LSCS. Okay, right? I hope you all understood the question as well as the answer. Okay, this is that previous classical cesarean ka question, so don't worry, I have that question also. Gravida 2, para 1, Gravida 2, para 1, living 1 with history of previous classical cesarean, presented at 35 weeks of gestation. Her presentation is now breech. Patient wants to try for vaginal delivery. What should be your next step? Take a repeat USG and then decide on the mode of delivery. Schedule elective cesarean at 37 weeks. Try for ECV. Try for internal podalic version under anesthesia at 39 weeks. Something like that was there, right? So, what will be the mode of delivery whenever you have a patient with previous classical cesarean? What will be the mode of delivery whenever you have a previous classical cesarean? So, previous classical cesarean is an absolute indication for a repeat cesarean section. Previous classical, once a classical, it's an absolute indication for repeat cesarean section. So there is no matlab in taking the USG and then deciding. I'm not going to do. When you try for vaginal delivery after cesarean, you call it as TOLAC. Here, whether the bacha is cephalic or whether the bacha is breech or whether the bacha is transverse lie, I am going to do again her elective repeat classical cesarean itself, because she once had a classical cesarean. And if you remember in your notes also, you have TOLAC is absolutely contraindicated in previous classical cesarean section. You can do TOLAC only when they have previous one lower segment cesarean section. So you cannot do TOLAC. So why do you want to decide on the mode of delivery after 2 weeks and repeating a USG? I am not going to do that, right? Why do you want to do ulta pulta for the baby? Anyway, you are going to take her for cesarean. Why will you hold the podalic version and all? So the answer here is schedule elective cesarean section at 37 weeks. Okay. So the best answer here is schedule this elective cesarean at 37 weeks. So the key point here is there are multiple things asked here and beautifully framed question, beautiful options. मतलब बहुत अच्छा लगा ये question देख these two questions like this अच्छा था. So I hope you all have also answered very well correct. So but the key point was previous classical. So again repeat the classical, right? Yes, again, one more question which usually I stress so much in the class and I make you draw this diagram. Those who have attended my session, I always make you draw this diagram. And last exam, this also is a repeat question almost. Secondary wave of trophoblastic invasion is by invasion of radial artery by cytotrophoblast, invasion of arcuate artery by cytotrophoblast, invasion of spiral artery by villus trophoblast, invasion of spiral artery by extravillus trophoblast. So the uterine artery is divided in the, I ask you to remember by the mnemonic of ARBS. Arcuate will give rise to radial, radial will give rise to basal, basal will give rise to spiral. Arcuate and radial will supply the myometrium, basal and spiral supply the endometrium. Right. So spiral artery is the one which is going to be present in the endometrium. Right. Now invasion of the spiral arteries is by which trophoblast? So obviously the trophoblasts which are coming out, those only will act for the invasion. There are two questions on the invasion of spiral arteries. Hai na? Very good, Trunal. Excellent. So invasion of spiral arteries, see these are the spiral arteries and it is done by extravillus trophoblasts. So there are two types of extravillus trophoblasts which will help in the invasion of the spiral arteries, that is interstitial extravillus trophoblasts and endovascular extravillus trophoblasts. So if I go back here, secondary wave of trophoblastic invasion is by invasion of spiral arteries by which villus trophoblast? Extravillus trophoblast, right? So the answer here is D, guys. Those who have answered D, correct. Not villus trophoblast. बाहर आके they are बाहर आ रहे हैं ना. Spiral artery बाहर है, तो ये villus trophoblast भी बाहर आ रहे हैं. So invasion of spiral arteries by extravillus trophoblast, right? And I've heard there is one more question also on the trophoblastic invasion. So normally remember that primary wave of trophoblastic invasion takes place at around 12 to 14 weeks. Secondary wave of trophoblastic invasion takes place at around 16 weeks. Remember this, we'll go back, we'll have one more question. There again, I'll tell you about that. So in preeclampsia, you have defective secondary wave of trophoblastic invasion. In hydatid form mole, you have defective primary wave of trophoblastic invasion. That is why in hydatid form mole, you have early onset of preeclampsia. Okay, what type of hymen is this? I think there was one image on the hymen also, no? So what type of hymen is this? So this is the septate hymen, guys. This is a septate hymen. Imperforate means you should not see any hole, any perforation. So this is the imperforate hymen. This is the annular hymen. When there is a septum, it's called septate hymen, cribriform hymen, and this is the parturious hymen after post-delivery. So I hope the question which they gave was septate itself. So that's about the types of hymen, and I think what you got was septate. So this was the image for the septate. Right, next question. Contraception of choice. Contraception of choice for 18 months. At 18 months when mother is breastfeeding and mother also has irregular and heavy bleeding. So what will be the contraception of choice? Now please remember, whenever somebody is breastfeeding, Varshil image was not clear, but we can't complain ki image was not clear. Okay, so here you cannot give Mala N. C ruled out first. Why C ruled out? Whenever somebody is actively breastfeeding, you should not give OCPs because OCPs decrease the breast milk. So you cannot give Mala N, right? Next, you will not give copper tea because copper tea क्या करेगा? Copper tea will further increase the bleeding. Copper tea will further increase the bleeding, right? Next, was there an option of progestasert? Actually, nowadays we are not using progestasert at all. Progesterone, remember guys, progesterone always causes atrophy of endometrium. Progesterone causes atrophy of endometrium. So progesterone causes atrophy of the endometrium, and long-term progesterone is always better. And progestasert is not used nowadays, but progestasert is a levonorgestrel releasing IUCD. Levonorgestrel releasing IUCD. Right? But norethistedone enanthate, norethistedone enanthate depot injection, this will also decrease the bleeding. This will also decrease the bleeding. But with norethistedone enanthate also you'll have irregular bleeding. So was there option of progestasert or was there any other option? So this between A and B, I don't actually understand why did they give B. So was it progestasert only or was it progesterone only pills? No, what was the B option? I'm not understanding what is the B option. Was the B option progestasert or was the B option progesterone only pill? Same option. So same option, actually A and B both go well, both go correct for this question. I don't know why did they give progestasert because we are not using the progestasert nowadays. But norethistedone enanthate say one problem is it still causes irregular, this also leads to irregular bleeding. So it does not subside the bleeding, irregular bleeding problem. So as of now I am telling you the answer should go for B, but I am not pretty sure on this. क्योंकि why did they give progestasert is one little hitchkey I'm having here. Okay, right? Okay. So yeah. So then right. So then B will be best answer. Why I'm not going with A is A will again cause irregular bleeding. ठीक है? So which site of implantation will cause severe vaginal bleeding? Which site of implantation will cause severe vaginal bleeding? See, if you miss the word of vaginal bleeding, then you will have, I think D option was abdominal. This is a very simple question. But if you miss the option of severe vaginal bleeding, then you might go wrong. Matlab in exam due to tension and all, if you would have not seen the option of severe vaginal bleeding, then you would have gone wrong. Okay. So severe vaginal bleeding, obviously when bacha is implanted at the level of internal os or on the cervix, then you will have heavy bleeding. No, ovary, tube and abdominal, you will have heavy hemoperitoneum. But and there you don't have heavy vaginal bleeding. They bleed into the abdomen. They don't bleed vaginally. There is mild pervaginal bleeding. But severe vaginal bleeding is when the implantation takes place in the internal os. So that is called cervical pregnancy. Cervical pregnancy treatment is always surgical, where you remove that pregnancy, otherwise she'll go on bleeding up to death, right? And the criteria for the cervical pregnancy is Palmans or Rubin's criteria. Palmans or Rubin's criteria. Okay, I hope this was the option and the question. Right. Lengthy paper, but I have reduced it to small, no? Uterine artery Doppler done at 12 to 14 weeks can detect IUGR, early onset preeclampsia, late onset preeclampsia, placenta accreta. So uterine artery Doppler done at 12 to 14 weeks will help us to detect the primary wave of trophoblastic invasion. But primary wave of trophoblastic invasion is defective in early onset preeclampsia. So uterine artery Doppler done at 12 to 14 weeks will help us in detecting the early onset preeclampsia. Yes, I know this was also not like this simple. There was a lot of case history along with this, but I am giving you the summary of the question as well as the answers. Copper tea is contraindicated in. So I heard students telling me that you got an image of copper tea and then they have asked where is it contraindicated. So copper tea is contraindicated in ruptured condom during intercourse, menstruation. Okay, why not IUGR? IUGR is something which is defective in the bacha. To identify the blood flow to the bacha, do you check uterine artery or will you check umbilical artery? IUGR के लिए you have to do umbilical artery Doppler, not uterine artery Doppler. For detecting the IUGR, you have to do umbilical artery Doppler, not uterine artery Doppler, guys. Okay. Yeah, one option I kept menstruation. What is the other fourth option? I don't know. What is the fourth option? Nullipara. Shreyansh, is it Nullipara? Immediate delivery. Okay, I'm writing immediate delivery. So copper tea is absolutely contraindicated in rupture condom during intercourse. So rupture condom during intercourse is morning after pill, the postcoital contraception, or when we have emergency contraception. And we all know that copper tea is the contraceptive of choice when there is a for emergency contraception. So we give it during the ruptured condom. You keep copper tea during menstruation because during menstruation thoda cervical os will be little open, so you can push the copper tea aram se inside. So you put it during menstruation also. And immediate delivery also you can insert post placental and postpartum up to 48 hours you can insert. But post molar evacuation after trophoblastic disease, this is contraindicated. Why is it contraindicated post molar evacuation? So the answer is C. Answer is C. So post molar evacuation after trophoblastic disease, it is contraindicated. Why is it contraindicated post molar evacuation after trophoblastic disease? So it is contraindicated. It is contraindicated because uterus is very soft and the IUCD can perforate the uterus. So that is why you should never give IUCD post molar evacuation or post choriocarcinoma, right? Excellent, Baidyanath Pandey. Excellent, very good. So you can we usually ask the woman to come on day 1 or day 2 of her menstrual cycle to insert the IUCD. Kyuki cervix will be little open, os will be open, so I can insert aram se. So usually you call them, it is not an absolute contraindication to put during menstruation. You can put. Okay. So that is why the answer is after trophoblastic disease. After trophoblastic disease or in trophoblastic disease is contraindicated. So if you feel any of the questions what I'm discussing with you is wrong, you can always send me the message to my Instagram account in the chat section. I'll definitely respond to you. So to my Instagram ID, or you can also message me in my Telegram so that I can correct the answers or the questions which you are feeling they are wrong. Okay? Right? I think this we have done already. Yes. 22-year-old female presents with infertility HSG done was this. What is the diagnosis? Was this the image which has come in the exam? So, agar it was given simply GTD. GTD is a absolute contraindication for copper T insertion. So, your answer will go for GTD itself. Yes, Pankaj, correct. So, this is something very tricky and very horrible image. So neither I am also an exam. Matlab, only examiner can decide what did he wanted to discuss on which one he wanted to decide. So on the whole, if you see here, the intercornual angle is looking less than 70 degrees and the intercornual distance is also looking less than 4 centimeters. So as of it cannot be didelphys or unicornuate, more in favor of septate. Bicornuate थोड़ा और दूर दूर होता है. I have the picture of bicornuate. This is bicornuate picture. So bicornuate में little you should feel R par. And this is the septate. So this one what he has given in the exam, no? So this is a septate. So if angle is less, then it is septate. If angle was less, then it is septate. Otherwise, it is not septate. So this is the picture of septate. This is the picture of septate. है ना? And this is the picture of bicornuate. This is the picture of bicornuate. So here if you go back and see, it looks like a septate. So I am giving you the answer of septate. But I might be wrong because I didn't see the image. R par means very far. Very far. Now North Pole, South Pole, little far. Unicornuate also I'll show you. I'll show you all. So this is the septate uterus. This is septate uterus. This is didelphys. When you see two cervix and two uterine cavities, so you should see two Leach-Wilkinson's cannula. This is didelphys. 2017 में you got unicornuate का image. This is unicornuate. So in unicornuate you will have banana shaped uterus. In unicornuate you will have banana shaped uterus. And you will see, more important, you will see one fallopian tube. You will see one fallopian tube. So did you see one fallopian tube or two fallopian tubes? So okay. So in bicornuate, the angle will be more than 70 degrees and intercornual distance will be more than 4 centimeters. And in septate, the angle will be less than 70 degrees and intercornual distance is less than 4 centimeters. If it was banana shaped, then it is unicornuate. Okay. Right. Next question. So this was that question which you were telling, no? Okay, at 22 weeks, primigravida came with profuse vaginal bleeding. Blood pressure is 110/70. Normal blood glucose. What is the site of implantation to cause severe vaginal bleeding? So it is at the level of the internal os. Severe vaginal bleeding, it is internal os. Absolute contraindication for cervical cerclage in patients with cervical length of 1.8 centimeters. Presence of fetal fibronectin in cervix. So presence of fetal fibronectin suggests that she is going into preterm labor or she is going into abortion. Okay. And I think she was how many weeks? Around 18 weeks. Prolapse of membranes into vagina, ruptured membranes, posterior placenta. So ruptured membranes is an absolute contraindication for ruptured membrane. Ruptured membrane is an absolute contraindication for the cervical and cerclage, right? So the contraindications for cervical and cerclage are when they have intrauterine infection, when cervix is more than 4 centimeters dilated, when they have ongoing bleeding, when they have uterine contractions, and when they have ruptured membrane. So this is directly from your notes, and all of you would have done it correct. C, ruptured membranes is an absolute contraindication. Yes, so I left one question, which this was the only question which I felt is out of the box, and we didn't read type में. So recommendation after surgery for vesico-vaginal fistula: abstinence for 3 weeks and avoid pregnancy for 2 years. Abstinence for 3 months, avoid pregnancy for 1 year. Abstinence for 6 weeks and avoid pregnancy for 6 years. Abstinence for 6 months and avoid pregnancy for 1 year. So I have gone through, it is not given in your Williams or anything, and NCBI has suggested that you can actually, usually they ask this patient to have an abstinence for 6 months and avoid pregnancy for 1 year. But there's nothing wrong even if they start having intercourse as early as 6 weeks. But usually patients are afraid and they have abstinence for 6 months and they avoid pregnancy for 1 year. Okay, so D will be the most appropriate answer. And I think one question which I missed was, what is the drugs which you use for abortion? Drugs use it for abortion when a patient presents to you at 8 weeks or 7 weeks. When patient presents with, those who left this question are very smart. Yes, this is a bouncer. It is always better to leave such bouncers. So drug used for abortion, patient presents with pregnancy of 7 weeks or 8 weeks. So 7 or 8 weeks or up to 9 weeks, the best drug which is used for abortifacient is Mifi and misoprostol. So day 1, mifepristone 200 mg per oral, and day 3, misoprostol 800 micrograms per vaginal. So Mifi and miso, right? Active labor, what was the question? I don't know. I missed some active labor ka question. Can you tell me what was the question on the active labor? I think just before the exam also I sent you regarding the active labor, no? Anybody, whoever can message me, please message me the active labor ka question. So this is on the whole, I think this picture also we were not having the clarity. If it was banana shaped with septate on, you can also have the septate form. Agar pura uterus was bent to one side and there was a small with no fallopian tube, then it is unicornuate with a rudimentary horn, right? So thank you guys. Good night. I know you're all so Trunal, I will be exclusively seen on eGurukul, Trunal, so you can follow me on eGurukul and DBMCI. So there's one labor question. I think magnesium sulfate toxicity, broken cord, all that we have done in the starting itself if you have joined late. So active labor ka question, please post me. I'll get back to you. So if you remember, just 2 days before also I posted in all the groups, all my Telegram and everywhere, Instagram, everywhere I posted. So you have to consider active phase beyond 5 centimeters according to WHO also now. So beyond 5 centimeters, it is active phase. So that question I didn't discuss because I don't know what is that question. So please message me that active phase ka question. I think rest all we have discussed and I think there is no problem. And this Post VVF also, please message me the options and I'll answer to you accordingly, according to the options. Okay. Thank you guys. Good night. Go sleep. Watch some movie. If you have not seen Triple R, go watch Triple R. It is available in it's available on OTT. So थोड़ा relax करो, enjoy. Don't be tensed कि कैसा हुआ, क्या हुआ, whether I answered it correct or not. You can still get a rank and get your dream seat if you're positive, guys. If you're positive. See, when you are positive, you attract a lot of positive and good things. So if you're positive, however you have given the exam, I tell you, sometimes like, third counseling may you go and you get your dream seat, or just before you, the girl or boy doesn't want to take a seat and they leave and you get your dream seat. तो वो सारे possibilities अभी भी बचे हुए हैं. तो बस positive रहो कि आपका ड्रीम सीट और ड्रीम कॉलेज मिल जाना है करके. राइट. गुड नाइट, स्वीट ड्रीम्स. थैंक यू. बाय.